All right, so then lastly, we want to stave off acidosis. Make sure they're not getting acidotic, and how do you prevent that? How do you prevent that? Is with a bicarb drip, right? So a bicarb drip is going to be given for someone that has acidosis and also someone has an AKI. We also mentioned it's for rhabdo too. That patient also is hyperkalemic acidotic too. But we want to make sure our pH is good. We don't want to overshoot it because that's going to be iatrogenic alkalosis. That's too much alkalosis. So keeping tabs on the bicarb levels is going to make sure we don't overdo it. And also, if they are getting like 2 liters in 2 days, because usually the bicarb drip is like at 100, 125 an hour. So it's good for 8 to 10 hours, right? So if you've done 2 days of bicarb infusion and there's no improvement, we could maybe have to discontinue it at that point. And we have more concentrated bicarb we could give, such as PO bicarb tabs. And someone might argue, well, what if I give like a bicarb push? It's not great to give bicarb pushes. It's going to cause a lot more problems than good. And we'll talk more about bicarb pushes versus bicarb drips. But bicarb drips are mixed as 3 amps, right? So 150 MEQs in D5 water. If it's in normal saline, A is normal saline, but also B, it's sodium, right? And this is sodium, sodium, sodium. So that's going to really, really raise the sodium, which can be a problem. If the bicarb drip doesn't work for like 2 days or so, 1 day, depending on how bad their fluid balance is, if their pH is still persistently low, then we have to unfortunately dialyze them, right? So remember the indications were AEIOU for dialysis. So that is A, acidosis, a sustained low pH. We tried to stop dialysis with giving bicarb drip, but it didn't work. Okay. All right, so avoid and treating hyperkalemia, as we mentioned, right? So avoid normal saline that induces hyperkalemia, and bicarb drip LR can help. We talked about giving some Diuresis, right, with these guys here. And then fludrocortisone is just synthetic aldosterone. That's all it is. What does aldosterone do? It's the only hormone that gets rid of potassium directly. So if someone's really, really hyperkalemic, we can get them some just straight up aldosterone, right? So that's the idea. So they got, they have metabolic alkalosis, then maybe you could argue to give normal saline. But, if they really, truly are hypovolemic, if they're acidotic, it's bicarb drip. That's what's going to help us out. Okay? And so aldosterone is working right over here. It's absorbing sodium in exchange for potassium. Our ADH is working over here, right? As we pointed out before, we have other antibiotics like our loop diuretics working right there, getting rid of potassium. We have thiazide diuretics working right here, wasting potassium. And we have our lonely acetazolamide over here right at the proximal convoluted tubule. And it's working hard to get rid of bicarb, and you're going to go ahead and absorb. You're going to have a buildup of CO2, which is a acid, right? So that's how our diuretics are kind of interacting. So a little more on diuretics. So we have K sparing and K wasting. As we mentioned, K sparing, there's only 4 of them. What are they? Seat, right? So it's going to be your spironolactone, eplerenone, which are its own class. Those are your MRAs. Those are the ones we use for heart failure. Okay, and they're great for heart failure. They stop aldosterone activity. Aldosterone, as we know, is going to stimulate angiotensin 2, and it's going to also cause ventricular remodeling and damage our heart more. So that's why it's great for heart failure. And then these other guys, amiloride and trantorine, have very, very few uses nowadays. There's like amiloride, or I think it's trantorine, can be used maybe for like nephrogenic DI, but there's very, very few cases for those guys nowadays, right? But what else? So these guys are working in different areas of the kidneys. Your thiazides, or sorry, your spironolactone, working right here on the collecting duct, and they are stopping the function of aldosterone. Therefore, your potassium level is going to go up, right? And then we have like amiloride and such. Those guys are working kind of over here in the distal tubules. They're changing the ion structure, and then therefore things are not getting absorbed, such as potassium. Or sorry, such as, I said that right? I'm thinking of thiazides. They're working on, but they are going to change the ion structure, and you're going to then have you're not going to get rid of potassium. All right, so the K-wasted diuretics. So this is everything else, right? Everything else being your loop diuretics, which work in the loop. That makes sense, right? They work on that ascending limb, that thick ascending limb, and they're going to block these little transporters. So therefore, if you block them, those things are going to get low. Your sodium, your chloride, and your potassium, right? Those are going to get wasted. Okay, and then we have what else? We have your thiazide diuretics. So thiazide diuretics work up over here on the distal tubules, and they're changing some stuff around. They get rid of they get rid of a lot of things, including potassium, but also some things get risen. So the mnemonic that kind of helps us with the side effects of this is called hypergluc, or GLUC. These things rise when someone's on thiazide diuretics. So glucose, right? Glucose gets elevated, so it's not great for diabetics. L is your lipids rise, so it's not good for someone who has underlying ASCVD. U is uric acid, not BUN, but uric acid will go up. So someone with gout, not a great idea. And C is calcium. So someone already has history of renal stones or nephrolithiasis, that's not great for them as well. It's going to potentiate renal stones. Okay, and then lastly we have our carbonic anhydrase inhibitors. So that's the one that's working right here at the beginning, working on carbonic anhydrase, and because of all the things it does and all the steps, it's going to eventually lead to a wastage of bicarb. If you're wasting bicarb, that means you are now have acidosis, right? So acidosis is a significant side effect of this, and the only time we give this is actually to acidify the blood. We're actually using it for its side effect. We're not using it, we are using it to diurese, but we're also using it to diurese and acidify the blood. Like they're still fluid positive 4 liters, but their bicarb is 32. It's like, what do I do? Do I still keep giving Lasix and thiazides, which is going to make the 32, 34 tomorrow? Or can I give acetazolamide to start making it a little more acidic? The problem is people don't pay attention to it, and it'll still be on there, still being given very, very rigidly twice a day, right, for 3 days, 5 days, and now the patient's acidotic. So it's almost a catch-22. All right, so we got to keep tabs on the I's and O's. We got to keep tabs on the bicarb. And how do you know what someone's bicarb is? In the BMP, you can look at the CO2 level, right? That CO2 is equal to the bicarb level. So that's a quick way. We don't have to get like ABG every single time, but just looking at the chemistry, it's getting it done definitely with some of the AKI.
CO2 is like an exact representation of it?
It's dissolved CO2. So as far as the
How does that work?
yeah. So bicarb and CO2, why are they equivalent? Is because when you measure in the lab, you're not measuring dissolved CO2. You're measuring CO2 that has reacted. And when CO2 reacts, it makes carbonic anhydrase, which makes bicarb. So it's equivalent to your bicarb. It's off by like 5 to 10%. Okay. Yep, pretty much. So then dialysis. So last bit of AKI is who needs dialysis? And as we were mentioning, it's AEIOU. So someone has acidosis, electrolyte changes, and we're looking at potassium, right? pH 7.1, 7.20, one of the two. The pH is low. It's just consistent low. How do we stop that from getting too low? We had a medication we could give to kind of prevent dialysis. What was that one called? We got bicarb that we can maybe give. All right, a bicarb drip can maybe stave off dialysis, stave off that acidosis. But eventually, if they start getting these different letters of the alphabet, AE, they have intoxications. These are the intoxications right here. They overdose on aspirin, right? They overdosed on what else? Ethylene glycol. They overdosed on antifreeze. Right? That's going to put them at risk for needing dialysis, right? There's no other way to get rid of it. And then O is fluid overload, and then U is uremia. So the BUN is elevated. The BUN is elevated. There's no medical therapy, no demand just yet that's going to lower someone's BUN. There's no like neutralizing agent you can inject to someone that's going to lower their BUN from 100 to 80, right? The only way to do that is with dialysis. So when you have 2 or more of these letters, then it's absolutely time for dialysis. There's no arguing. There's no evidence that says, oh, I can wait for 3 letters. No, once you have 2 letters, it's time for dialysis. It's time for it now, not time for it tomorrow when we have labs and all these other things. It's time to get dialysis immediately. When you have 1 letter, that's where you're concerned and you're looking out for the other letters, right? It's like, don't drink antifreeze, stay away from it. No, I'm just saying they have acidosis, and now you start to see the I's and O's are positive 1.5 liters, positive 2.5 liters, positive 3.5 liters, and the bicarb is now 18, 16. That's 2 letters, right? That's acidosis, and that's fluid overload. So just those 2 things alone means it's time to get dialyzed, right? So don't wait on these patients, especially if they're hyperkalemic and acidotic, because we know the hyperkalemia causes acidosis, and acidosis causes hyperkalemia, and hyperkalemia causes acidosis, right? So that's going to be a bad situation. So a little bit about RRT, renal replacement therapy. What is it doing? So it is, you're taking blood from the body, or you're taking it via, if blood goes away from the heart, what is it called? What kind of tube is that called if it goes away from the heart? It's called an artery, and arteries are red classically. So that's why they're labeled red and blue, right? So red is going away from the body, and blue is going return to the body, right? Oftentimes they call it arterial. That's technically wrong, but it's not wrong because it is going away, right? But sometimes they get confused. But either way, this is all coming from one single vein, right? It's not coming like, it's not inserted in a vein and an artery like ECMO therapy. It is inserted just in a vein, like it's a larger triple lumen catheter, but it's 2 lumens. And the blood is going away from the body right here, right? So here's our arterial axis. It's going away like that. And it's going through these little fibers here, and there's thousands upon thousands of fibers. Does anybody have a cheap pen from Staples? Yeah, so this guy right here, it'd be nice if it was red. But anyways, you can see the filament in the middle there, right, that has the ink. That's where your blood is going, right? So at the top, it all filters in from the top, and it all filters through the middle right there. And surrounding the ink cartridges there is dialysate. So, and that membrane is semi-permeable, so it's able, so things are able to move across, right? So the blood is in contact with dialysate through a semi-permeable membrane. It doesn't like get mixed. It's just that membrane is keeping it separated, but all the fluid can go left and right, right and left, right? So we have blood and we have dialysate. And if you notice, it's going opposite directions. And they've done research to say that's the best thing to do. If you have it going the same direction as blood, then you don't get the concentration gradient equal across the whole thing, kind of like accumulates at one end versus the other, right? So it's going in a countercurrent mechanism to it, right? So it's going this way, whereas our blood was going this way, right? So that's going to provide a concentration gradient, right? So everything moves by diffusion. Everything in the universe goes what? High to low, right? So if we have, what do you want to do in AKI? What do you want to get rid of? Fluid, good. We'll talk about fluid next, right? But what's another thing you want to get rid of? What toxin do you want to get rid of? Potassium, right? So K is 2 over here, and my K over here was 4.5. So it's going to go from high to low, right? So it's going to go from 4.5 to 2, right? And someone with what else do you want to get rid of? Or indications for dialysis? Uremia, right? So they have a BUN that's elevated, right? So BUN is, well, they probably don't need dialysis if BUN is 30. Let's say BUN is 70, right? And then what's the urea of the dialysate? We're going to say we're going to put waste products in our dialysate? Probably not, right? So that's why it's 0 over here. So we're going from 30 to 0. So the BUN is going to go down, right? As it is going across this membrane over here. It's just going back and forth by diffusion, high to low. And as we talk about like chronic kidney disease, those patients have low calciums. So the calcium might be a little bit higher on this side compared to the other. So here's 2.5 and their calcium is 1.2. That's probably a little higher. That's probably ionized calcium versus our total calcium. But either way, the calcium would go from the dialysate into the blood in that case, right? Same thing with bicarb. These patients are acidotic. We want the bicarb to be going from the dialysate into the serum so we can fix it, right? So use the bicarb is 35 over here, right? And a bicarb over here was, well, let's say CO2 is 25. I'm not sure why they changed it over. Right? I guess they're also witness protection. But we're going to go from 35 to 24, right? So that's going to make my bicarb go up. So that's how dialysis works, right? That's the purpose of dialysate. The other thing that dialysis does is this is under pressure. There's pumps involved here, right? So there's pumps that are pumping and pumping and pumping and pumping things and pumping this way, and that's going to actually push things across. So it's high pressure on one side and lower pressure on the other side. And it's also low pressure on this side because it's pulling it this way. So that's called ultrafiltration or convection that they're doing. So convection is another, or it's down there. So convection is the movement of solutes, whereas ultrafiltration is the movement of solvents or water. So we're pushing water across with the fluid overload, and we're pushing solvents across, or solutes across, such as like inflammatory mediators, for instance, or things we don't want that are in a large amount, like things that are things we ingested, like ethylene glycol or salicylates. It's pushing those things across, right? So that's how dialysis is pushing these things across. And of course, we have to have access to make this happen. And the access is usually temporary at first, right? And if they still need access after about 21 days, then we're going to get a tunneled catheter, a Permacath, right? Cath is the temporary one, right? So we place that in place, and hopefully we can get 2 types of intermittent dialysis. So intermittent is usually about 3 to 4 hours. That's where you're going in, you're doing 3 days of kidneys work in about 3 to 4 hours. So you're gonna bam, you're gonna pull all that fluid off. You're gonna make them what? Hypotensive, right? And it's great if someone's K is high, you're gonna get the K down from 7 or 9 all the way down to 6, easy drop in the K. All right, but moving that fluid around that quickly can cause a lot of problems. So one of those problems, especially with like first-time dialysis patients, is this disequilibrium syndrome, where the brain doesn't catch up with the movement of solutes as fast as the serum does, so then it gets cerebral edema as a result. So, intermittent hemodialysis has its utility, but in the ICU, it can be really nebulous, or really, nefarious, or it could be something that's going to be difficult for someone who is hemodynamically unstable. So an hemodynamically unstable patient, they would benefit more from what's called SLED dialysis. That's called slow, low efficiency daily dialysis. They're in dialysis every day, but it's like 8 to 12 hours, right? But a dialysis nurse, they make money based on session. So if they can do four sessions in the space of 12 hours versus one session, it's really hard to argue for them to do it. And they say, can't just the ICU nurse do it? So that's what we did. So we said, okay, then we'll just do what's called continuous renal replacement therapy. We're doing dialysis continuously. We still have the filter, we still have the pumps, we still have the dialysate. We're doing, and it's also actually done sterilely, versus this one is just clean technique. All you're doing, they literally hook it up to the sink right next to the bathroom, or some people drop the JP drainage, right? So it's right there. And if you look at what they're pulling from, it's like a bucket of vinegar and like a barrel of, it's not a clean process, right? Or it's not a sterile process, I should say. It's a clean process. They do their best. They do tests to make sure there's no microbes growing, no Hep B growing. But it's the best of both worlds. They're trying to get dialysis as quickly as possible and for as many patients as possible, right? But doing CRRT is a sterile process. And there's a whole class on CRRT where we go over all these things in detail about what, all the different modes, because it got really crazy, right? So there was all kinds of modes out there, starting with the 70s. There's SCUF, there's CVVH, CVHD, CVHDF, and there's actually like 12 other modes they did. But in the 90s, they said, that's enough. They met on a mountaintop somewhere, and they said, no, this is the mode. What are you doing? That's this mode. What are you doing? That's this mode. So they kind of stopped the madness back then. Okay, but there's all kinds of things we can do with CRRT that we can't do with dialysis or intermittent hemodialysis, and vice versa, right? For instance, CRRT is 3 days of work in 3 days, right? It's continuous. So someone's K is 9, there's going to be 6 in 2 days, right? So that's not great. So that's where like intermittent might be more beneficial. And the speed at which this is going, it's going at 300 mLs per minute, right? So how much volume do you have circulating around? About 5 to 8 liters per minute you're circulating, about good 5 to 8 liters that you have at all time, 8 to 10 liters at the most, right? So 300 mLs a minute, all your volume is leaving your body that many times in a session of 3 to 4 hours, like 96 times at least, right? So that's why these patients feel fatigued afterwards. Like, come on, why can't you get up, right? It's because your blood literally left your body that many times. So CRRT, again, we go into more detail in the CRRT class, but it's sterile. There's many different modes. The mode that we use nowadays is CVVHDF. It uses filtration, use a lot of pumps to really pull all the solutes, like sepsis patients have all these bad complement systems and cytokine storms. If we get rid of the cytokines in CRRT, then they might have a better outcome afterwards, okay? And it's slow correction. All right, still about 300 mLs a minute, but like dialysis, go all the way up to 600 mLs per minute when it depending on the machine. Okay, so CRRT has all kinds of different modes we're doing. It's doing all the same things we talked about before: diffusion, convection, ultrafiltration. It's really pulling stuff across, and it's the dialysate we can change. If you've seen someone set up CRRT, they're getting all the different fluids, which are sterile, right? They hang sterile fluids. It's a sterile process to make sure that we are pulling the solutes that we want to pull. All right, so finally the complications of AKI. So not just like, the acute complications, but what happens after you fix someone's AKI. Sometimes you don't fix it and the kidney is dead, right? So the kidney has different levels, right? Base KDIGO, is it greater than 4? Is it 0.5 and a 1.5x change or not, right? A 2x, 3x change. And sometimes, as you said, 3x change is like a 50% chance of mortality. But what about the kidney itself if they do survive? It could end up on permanent dialysis at that point. Or they can be spit out at a different level of CKD. All right, so they could be stage 1, 2, 3, 4, or 5. Stage 5 is dialysis. All right, so they can spit out at stage 3, and then now we have to try to prevent progression if we can. Okay, so that's the idea behind AKI recovery, is they may recover or they may not. And there's actually a little interim period before they actually, you can actually say they have CKD. So you have AKI over here. There's this called acute kidney disease, which is kind of confusing because that's what AKI used to be called. But it's that 3 months after the AKI. So you got 7 days. If they're in the ICU, it might be 21 days, right? But basically after they get out of the ICU, is their kidney function get better or not, right? And usually what happens if they are getting better is they're going to have what's called post-AKI diuresis. All the BUN they're building up over the last 7 days, 21 days even, is now getting ejected. And what follows BUN is fluid. So now they're at risk for hypovolemic shock and AKI when they are actually recovering. So that's the kind of the caveat or the thing we want to pay attention to, is make sure they're not peeing out too much, right? So there's called post-AKI diuresis. Diuresis can happen here, and that can lead to an AKI. Now you're back to square one, right? So we got to be alert to someone who is peeing and the creatinine's coming down. That means they're recovering, right? That means they are getting over their AKI, right? But if the creatinine starts going back up and the urine output starts going back down, that means they're going back into AKI again. Okay, but once they are done in that first 3 months, the nephrologist is going to follow them, and they're going to look, say, hey, let's see what your creatinine is. Let's see what your GFR is calculated to be. Let's see what your albumin in your urine is. That's going to tell us how much our glomerulus is destroyed because it's not keeping protein back. And they can then see, do you have diabetes, hypertension? Because that could put you at a higher risk. We got to get that under control. So they can end up at whatever stage 1, 2, 3, 4, or again 5 with a permanent need for dialysis. And CKD, as we'll find out, is irreversible. You don't get, it's at stage 3, I should say, right? So once you hit stage 3, 3A, 3B, then you can't come back, right? It's a point of return at that point, and then you're out of luck. You have to then, hopefully slow down the progression, but you cannot stop the progression. If it's stage 1, stage 2, maybe really, really early stage 3, you can maybe bounce back and get full kidney function again. Okay. The only fix after this point, if you do end up in dialysis, is what? Transplant, right? So TX for transplant, question mark, right? And they have to meet criteria. They have to be the right age, they have to be the right comorbidities, all the other fun stuff.